Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Thanks for joining me today, guys, at the ERAS Congress in beautiful Lisbon, Portugal. It's been a couple of days of really intense science and research around ERAS, which we love, and we want to spread the message further around the world. But why do we still have surgical wound complications? Can someone please explain?
Well, it's that sharp thing that goes into your body that causes a wound. And yeah, so there's that. But I think part of ERAS is about looking at the whole picture, isn't it? So one of the simple things is to make a smaller hole. You know, so laparoscopic robotic surgery, that is clearly a really simple yet complex change that we've made. So one would hope minimally invasive surgery would lead to fewer complications in wounds, but that's just one element of it. So, Tom?
Well, I think there's lots to still to discuss, because even though enhanced recovery or ERAS is so widely known throughout the world, if we look at the outcomes data, it's not yet implemented by every hospital in every surgical specialty. So the mission for the ERAS Society, but also us as clinicians and researchers, is to try and spread that message. The thing that drives me is if my mother was going in for surgery in the hospital local to her, what care would I want her to have? And it's enhanced recovery pathway every time. And until we've delivered that for everyone's parent, I think we've got work to do. And I think wound care and incisional care is one of the elements of good surgical practice. So to talk about it in the same sort of conversation as enhanced recovery makes sense to me. So I think it's just one element of lots of elements that we can improve and optimise.
I would agree, Tom. And likewise, Angie, minimally invasive surgery or MIS, and incorporating wound care into the ERAS pathway. But what I've found in my country, in Australia, is ERAS is still a bit of an unknown quantity. What do you think some of the barriers are in trying to implement ERAS, but being aware about ERAS?
Yeah, I can share my experience here in Portugal. It's the same. There are not a lot of hospitals that fully practice ERAS, but most of the hospitals have some kind of ERAS trying to get to work in their reality, and I think that's the beginning. It's better than nothing, and I think the key is to just start and go for what you can do. It can be either enhanced physiotherapy after surgery, it can be preoperative, whenever it's better on your reality. Just spread the word and try to start doing something. I really think that's the way of doing it.
And in your experience, Angie, how long has it taken for your facility in Scotland to become true believers?
So we were very lucky in that we had Professor Ken Fearon working with us in Edinburgh, who was one of the co-founders of the ERAS Society, sadly died a few years ago. This was all very much the Henrik Kellett rabbit out of a hat. This can't be possible to reproduce. So there were people going to Denmark from all over the world to find out how this happened. How did this guy do this? And we were fortunate to be involved in the early European study group. So I was just a nurse working in high dependency, looking after colorectal patients, and heard about this ERAS thing and thought, no. You can't possibly feed people. You can't get them up. That's dangerous. No, complete skeptic. And so that was in 2004. So we have been trying all those years to improve compliance to ERAS, and we're still not there. And, we would admit by, ERAS Society guidelines, using the database, etc., you will very rarely find centres that do everything every time. But we have definitely made huge leaps and bounds for perioperative medicine. Massively different. And I still struggle sometimes with day-to-day questions from nurses around what can this patient eat? And then you ask the surgeon, and that's a different surgeon to the one that was on yesterday. And
Yeah.
so these are real-time complications from our not for the patient's recovery, but just for our institutions. And I think that the biggest barrier to ERAS is resistance to change. Why should we? Are you saying that I'm doing something wrong? It's about nurses very much want to do everything they can for patients, but we won't go down the road of we don't have enough staff, we're not properly educated in terms of the ERAS concepts. But we are trying, and I think have spent time identifying the most important parts from our point of view is the pre-op preparation and education of patients, the early mobilisation, the early nutrition, and you need patient buy-in for that. And so that's where nurses will always be the nurse advocate, but also the patient advocate too. So that was a long-winded answer to your question, but I think
That's
it's
fine.
important to say that we are nearly 2 decades on and we still have a lot to do.
2 decades. So do you think probably, say, Tom, developing therapeutic relationships with the patient is a central tenet in successful outcomes in ERAS from a physiotherapy perspective?
It is. I think we used to call it, when we implemented choreographing the patient and their family's expectations. So what I mean by that is, and that's a different word to managing, because that sounds a done to. Choreographing is sort of describes revealing what's going to happen, why it's going to happen, and why it's of benefit to the patient. Now, of course, you want your whole team to sing off the same hymn sheet. So that's the administrators, the secretary who phones the patient, who books the operation, to your cleaners and your person who brings around the lunch. One comment, from the person bringing around the lunch, saying, "Oh, I can see the physio's coming. You might want to take your painkillers. Things like that." One comment such as that can undermine everything. And the key part to that is, how can you choreograph a patient's expectation if you don't have a standardized pathway within your institution? Because if I tell them something's going to happen when they come in before their operation and I prepare them for that happen, I lose that patient as soon as something different happens that's not been explained why it's different. So to truly manage and help a patient through that process, you do have to have the bedrock of a standardized process, because otherwise what I'm telling them is just make believe. It doesn't correlate to what they're going to happen. And I think that's a key message, because everyone talks about preoperative education. It is important, but it has to go with the other elements. I think the other thing is, you have to listen to patients too. You have to get their feedback. You have to understand what matters. And we will agonise and have discussions in here about different drugs and different clinical bits, but that can all be undermined if the food's cold, they can't park, the organisational and the contextual issues. So it's a whole team, whole hospital quality improvement project, and ERAS is not the aim. It's a vehicle with which we can standardise care to help improve clinical outcomes for our patients.
Well said.
Yeah, very good. I agree.
Agree.
Yeah.
You've said that before, haven't you?
Maybe.
Yeah, a few times.
Times.
But I believe it, and I think
Yeah.
I think it's important. And when I used to work on a consultancy basis for the Department of Health in England, I was asked to go around and help other hospitals implement enhanced recovery. And there was a really good thing we used to do. We used to randomly pick 5 members of staff. And as we were doing the walkthrough, I would just I'd peel off, the surgeons would be at the top, I'd peel off and just ask different members of the team, so what is your pathway? What happens? Can you tell me each step? And I knew straight away that it was all sort of smoke and mirrors if they got 5 different answers. Because when you ask the surgeon, it says, this happens every time for my patients. Yeah. But if you start asking the administrators, they're like, oh no, that's what should happen. But what really happens is X, Y, and Z. Yeah. And that's when you get to the reality of things. And then that's when you get to the element of, okay, this is our baseline. This is what's happening now. This is what we need to improve. And, so as a tip for anyone, go back to your hospital, ask 5 different members of staff to describe.
I won't do that. I'm sure I will get 5 different answers.
Yeah, but
I'm sure of that.
But we should all know each other. Yeah. And I, with my own profession, when I talk to them, I do a lot of training about the surgical procedure. And I said, what do you know? What do you mean you don't know the prosthesis? They say, well, we just do the same thing. Well, how do you know you do the same thing? We should want to know. We can want doing each other's jobs, but we should want to know the details of each other's jobs so that we can work together, so we can understand each other's roles, so we can improve things. And that's really important.
It's breaking silos, essentially.
I like the not breaking silos, but building bridges.
Oh, there you go.
Because the silos will always exist, but
It's
I think
true,
that's
in
a
a
reasonable
way.
thing to say. You know, that we will always see things from a different perspective, because we're different people in different professions and we have different priorities, but we all have the patient's well-being at the centre of that.
Right at the centre, patient-centred care.
Yeah, and coming in again to patients, wounds are really important to patients. It's a big part of what they worry about, and most of the times, even in ERAS, it's not very big thing in ERAS, and maybe we should start thinking about that, because it's really important. If they can shower, if they feel okay with the dressing, it doesn't stop them from moving. It's really important, and I think it should be integrated into ERAS.
Agree?
Absolutely. And again, as we were talking in the session today, it's also important to understand that all of the team need to understand the dressing and how it works.
Of course.
So
I got a few problems.
You're using new dressings, but your team have to understand what they can do, and they've all got to say the same things, and the patient has to understand as well.
Of course. It's really
And that's crucial. As length of stay is reducing across all our surgeries, then the patient is going to do more of the surveillance themselves. So unless we educate them and their families about what good healing looks like and when there's problems, then we're missing a trick.
Yeah, and if you explain them what will happen and what are they should do, they are eager to help. And they my experience is that they usually like having some kind of part monitoring the wound and the dressing. So I think if you explain, they will do it really well, even better than us.
So there's actual evidence in literature saying that patients want to be involved in their care, and just ask us for, if you want us to do something, just ask. And I think that that's the difficulty within our realm of, being a clinician, is that we do unto patients, whereas now they're maybe getting a bit more control and a bit more of a co-production of recovery. So we need to let them take some responsibility as well.
Trust them.
Trust them that whatever you've told them before they come in, that you are actually going to do that, that, practice what you preach, that what I've just pitched to them pre-op actually happens, and it doesn't depend on which surgeon is on that day, then they will understand and they will completely buy into it. And I've noticed a huge change in patients' compliance, for want of a better word, because if you tell them, then they will usually do it. And if there's a reason for them not doing it, if they're sore, give them analgesia. If they're sick, give them antiemetics. If they don't want to, give them a talking to. In a very professional, kind, compassionate way.
Of course.
But they need to get up.
And
I think
get
it's
moving.
usually that one, the first morning post-op, they are quite, they've had surgery. And family members as well think that, gosh, you're being a bit cruel.
Yeah.
They've just had surgery.
You're being bossy, don't
Yes.
you? Pour them. Pour you.
Yeah, I know.
Yeah.
Get up.
So it's about that health literacy
Yes.
and the education, and just giving them the tools they need to self-manage,
Yeah, absolutely.
take responsibility for their care.
And I do think following discharge is another huge area that we've not tapped into. That we need to get technology to help us to, diagnose and treat wound infections in the community.
There has been some work done in the UK in that space by a team in Birmingham. And the results are interesting,
Yeah.
very interesting indeed, in that if we're going to be using those types of modalities, we've got to be wary of false positives and false negatives and over-diagnosis of surgical wound complications and under-diagnosis as well. So it's still in its formative stages, and we have a trial underway in Perth at the moment looking at exactly that, whether it has a clinical utility, or do we want the patients coming back to clinic so you can do the good old-fashioned face-to-face, head-to-toe clinical assessment. So I think there's lots of research to be done in that space, indeed. But what's been one of the big takeaways for you, Tom, in this Congress so far?
So far, I think we were at the 9th ERAS World Congress. We missed a few years due to COVID, but I think the big thing that's hit me is we've got nearly 500 people here. The sessions are well attended. People are from all around the world, all the different professions, and people are super engaged, which is fantastic. So what we've just been talking about, the implementation of these changes, yes, they happen in processes and in systems within our hospitals, but it's about people.
Yeah.
It's about educating people, getting people to come together and make changes. So I think it's fantastic that all the people are here, and then I just hope they can all go back to their institutions and inspire the people that they work with, to change their pathways and improve them. So I think the takeaway for me is, all this time on, we've still got lots of work to do. We've improved a lot of things, but as we improve one thing, my area is hip and knee replacement. We can do day case surgery now, which, to think about that 15 years ago was a massive change, which is fantastic. But as the data I showed, patients aren't recovering as well as we think they might. And so there's still work to do. And, that goal is a pain and risk-free surgery. Now, whether we'll ever attain that is another question. But we've got to keep going towards it, because we all might need surgery, and I think I'd rather have the pain.
I'd want to be in an ERAS pathway.
I'd have the pain and risk-free surgery over the other surgery any day of the week. So we've got jobs for a good few years yet, I think.
Thank goodness. That's really good to hear. Angie, for you?
I think so. We chaired a nursing and AHP and ANP meeting yesterday afternoon, and again it was standing room only. There were over 100 people in the room, I think, and very engaged. It's very, very difficult to represent an entire cohort of people around the world, but trying to pull together like-minded, enthusiastic people to talk about current nursing and AHP duties. We have actually sent a plea out. Tom and I are looking for more allied health professionals to step forward and help us with this initiative, because we need more publications, we need more research, we need to understand what it is. We know there's barriers to change, but what is it exactly? And we are not going to get more nurses. There are no more nurses. So you need to take the nurses that you have, educate them, support them to make these changes, so that you get the better outcome for your patients. But redesigning tasks, so the person that brings the tea trolley, give them more information about giving your patients dietary advice, or encouraging them to sit up straight before Angie, the ERAS nurse, comes along, because she'll shout at you if you don't. These kind of things. That is trying to make everyone enjoy what parts of their job that they can at the moment, because post-COVID we're broken a little bit, and to see development and improvements, the people on the shop floor don't see that. We see that because we are publishing and producing evidence and displaying it in front of 500 people in Lisbon. But they don't see that, so we are responsible for taking that message to them, that this is actually working, guys. It might not feel important right now, but that supplement drink, that's so important for everything else that comes after. And that we are all part of the same goal and the same journey, actually. And what we do has a direct impact on what happens next. So, the nurses and HPs are awesome. So
it was a great session, and it was well attended. It was great to hear the enthusiasm and the passion that ERAS nurses have for ERAS, and it'd be great to see even more of that as well. And I'm sure it will come. And for you, Sarah?
For me, it has been really important, because I've been learning a lot. Here in Portugal, we still have a lot to do and grow in the ERAS community. But I'm very happy to see a lot of Portuguese healthcare professionals, either nurses, doctors, and even nutritionists. I've met some of them here, so I'm very happy that Portuguese community is responding well to this. And I look forward to make my country bigger, ERAS promoting country. I think it's really important here in Portugal too. And also, I'm really happy that we are trying to include incision care in the ERAS community, and I hope this subject keeps growing in the ERAS community. I think it's
sure
important.
It will. Some great advocates. You're all great advocates for ERAS. And for our viewers that are watching, a little pearl of wisdom if you're just trying to get ERAS off the ground at your facility. Go for it. What would you tell them?
Can I use a Disney reference and just say...
You can use any reference you want,
just
as
keep
long
swimming.
as it's PG.
Just keep swimming.
Keep swimming.
It's difficult and challenging, and you sometimes cannot see the wood for the trees. But it is worth it, and you will get, you know, it's very, very challenging to, but it's not, you have to bring everybody along with you, you know. So I think that getting the people on the shop floor, on the coal face, to understand why you're doing it. And if you don't succeed, try again, and then again, and then again, and try and ask them what it is that causes them the most frustration and anxiety, because ultimately nurses want to give the best care, they want to give the best safe care, and they have their own skepticisms as well. So it's education. Speak to your MDT, involve them in any decisions that you make. If you're going to redesign the care pathway, ask the nurse, because she's the one, they are the ones that are going to use it.
Thank you. Tom?
Yeah, I think it's improvement in healthcare always has a context-specific flavour because of the differences in where we work. But my advice that I was told by one of my first sort of practice educators when I was training to be a physio, I think it still stands. And he says, you've got two jobs with the patient in front of you. You've got to think how you could treat this patient the best you can today. And then you've got to be thinking, how can you treat the next patient even better? And I always think back to that in my research and clinical practice. How can we be making improvements? And if we're thinking like that, we'll arrive at ERAS because the evidence is there that it should be there. But as a clinician, that on an individual basis, that still drives me today. And then, as Angie said, on a team basis, there's all those other elements. But it's a multidisciplinary effort. You need to work together. You need leadership. You need a culture, an organisational context to support that. But on an individual level, each patient you see, how can I give this patient the best treatment today? How can I treat tomorrow's patient better?
Thanks, Tom.
I'm taking notes here. I don't have any
It's your
advice. My
turn.
advice would be only just listen to the patient and focus on the best care you can give to the patient. That's my experience, and has this way of working has helped me a lot in focusing what should I do, what can I do better, and that's my only advice. And regarding ERAS, I'm taking notes as you were speaking.
Well, it's been great to chat with you today and have a candid discussion around ERAS and wound complications and all those fun things that drive us to create change. So thank you, Sarah.
Thank you.
Angie. Tom?
Thank you.
It's been my pleasure.
Thank you,
Thank
Sandy.
you.
Thank you.